Good evening, friends.
Good evening, sir.
Can we start? Can we start the lecture?
Yes, you can start.
Okay, just before I start, let me open my presentation for today. Then we can be able to start. It's why taking some time to load. Just be slightly patient when the presentation opens. I can be able to start. Ah, ah, ah. This computer is very slow like this. My desktop is quite congested, and so it is taking quite long to open this document. So let me close some of these documents so that we can be able to see them. Anyway, before as I wait for this thing to open, let me just give you a brief of. Let's have a brief of what we discussed yesterday, so that as we enter into the next lecture, which could probably be our last or our second last for this particular module, we are able to continuously understand why this module is very important. And yesterday, we were able to further look at data analysis for demographic events. Mainly, we were looking at mortality, fertility, and how to measure migration. And we said that fertility has different measurements and different indicators that we can use to measure one replacement level, but also what we can call the total fertility level. But we were also able to discuss that you can use the data that you have to understand age-specific fertility rates of individuals. And we discussed that it is very important to use these measures because they help us determine our project designs, but also interventions that we could have if we are to solve some of the health issues that are arising in the society that we live in. And we are further able to discuss some of the measures uh, of mortality, being crude mortality rate, even we are able to understand age-specific mortality rate. We're able to discuss issues regarding cause-specific mortality rate, and we discussed that if you're to understand the mortality trend of your society, of your community, you must be able to understand how these measures can be done. And we also needed to allude to the fact that you must be able to understand uh, how to interpret these measures. Per se, we looked at in infertility, we looked at the general fertility ratio that tries to give us a general picture of how the women in that particular society or population could give birth or how many children they can give birth to. We also discussed issues of parity, the number of live children born to a woman, total fertility rate. We were able to discuss what fertility is, among others, and in mortality, I mean migration, we were able to also look at how migration can be measured. And we said most times you have to use the difference between birth and deaths and your base population because sometimes it is not easy to measure migration because of the different trends all individuals may have, and but also because of the fact that migration migration is a temporary
Excuse
aspect.
me. Today,
Yes, please.
today you are not sharing the screen.
I'm going to share. I'm just giving a brief
It's okay.
of what we discussed yesterday.
It's okay.
So I'm here to. I'm just giving a brief of what we discussed yesterday, and today, let me just share with you the screen. Let me share the screen. My screen sharing icon. Okay, good. Let me share with you what we intend to cover today. Just a minute. Are you able to see my screen?
Yes, you can see.
Yes. In today's lecture, we want to look at this aspect of demography and health, but specifically, we need to go back with three major objectives. And one of the objectives is that we need to understand the connection between demographic trends and health related issues. Another objective that we need to understand today is the relevance of demography for the study of health status, health behavior, and healthcare delivery. And lastly, we would want to understand the demographic factors and how they affect population health status. These are the three main objectives that this lecture is going to focus on. And by the end of this lecture, it is only paramount that you're able to go back with the information per those objectives I've listed up there. So, just to give us a brief of what the demographic, how demography relates or correlates with health status. Health conditions are not equally or even randomly distributed within a population, but are distributed correlated with the demographic characteristics of that population. This lecture expands the discussion in which these compositional variables were introduced to describe and explain differentials in fertility, mortality, and morbidity. So, what we're saying is that disease or health problems do not just, it is not a random distribution or it is not equal that uh, this village should have two illnesses of cancer or this particular disease, or this particular village should have a certain number of health problems. Health problems are distributed according to the demographic characteristics of a particular uh, population. So it is not rocket science that every society should be having a health problem. It is distributed according to the health, the demographic characteristics. That's why in this lecture we want to associate the particular health status to the characteristics of that particular population. So in this lecture, we want to expand the discussion on how these particular variables, these demographic variables, influence the aspects of fertility, mortality, and morbidity in that particular population. And we want to start with the factors that are associated to health status, meaning we are discussing a demographic characteristic vis-a-vis a health status. So we want to start with the biosocial characteristics of the health status of a population. One is age. Now, there has been a very long standing acceptance of the notion that health status is closely linked to age. However, in different studies that have been done, person ages, the more numerous and more serious health problems become. So what we're trying to say is that according to research, as people age, health problems become more severe. But we've seen this assertion or this belief being subjected to queries over very many researches. One, because as people are born, if the assertion was true that when people are aging, the serious, there are more serious health problems, then uh, at younger ages, you may realize that people are more vulnerable to certain diseases than they are at their middle ages. So that is where this assertion that as a person ages, the more numerous or the more serious health problems is being criticized. While there is some truth to this assertion, research conducted in recent years indicates that the situation is much more complex than had been previously thought. Patterns of mobility, disability, and even mortality display complicated relationship with age structure. Just as I've said, you may not be able to assert that as someone is growing old, their chances of getting a certain disease or the chances of getting more diseases increases, because we've seen in many of the societies this is not true. So what we need to understand, however, is that age contributes to the health status of an individual. How is this possible? If we looked at our relationship in the pyramid, you realize that when children are younger, the possibility that they may be vulnerable to higher mortality rates is high. Why? Because at a younger age, an individual has a low immunity, uh, and they are vulnerable to catching illness if the environment they are staying in does not practice healthy uh, practices. However, as an individual is aging, they are also more vulnerable. That is why when you see in the recent COVID-19 infections, if you saw the graph, you realize that the rate of vulnerability was more among young children than in elderly people. However, what is key for us to understand is that this is not the notion, or this is not always the fact. That is why we could still see that young people aged 30, 20 could still succumb to COVID-19. However, we are not stating that age cannot influence the health status. That is what this entire characteristics is talking about. Another biosocial characteristic that influences uh, an individual's health status is what we call sex, one of the most perplexing ones, but it is also a very important correlation. And in the context of sex and health status, it is very key in trying to explain some of the trends in, uh, in health status. There is perhaps no other demographic variable for which differentials in health status are so clear. Yet at the same time, there is probably none of which more questions are raised concerning the validity of findings and the possible explanations for the apparent relationship. So what happens is that for every other disease that we have in our community or in our population, we relate this particular illness or this particular health status to a sex variable. The demographic variable being sex, and the health status being the variable we are comparing it to. So what happens is that if there were cancers in a particular population, we would want to know how many females and how many males are having this particular illness. So if there are more females than males, then we can start to attribute, we can start to try and understand or try to analyze these differentials. So we may not, the last statement, we may not necessarily come to a conclusion or have a possible explanation as to why more females and males have a cancer differential. But what is key to for us to note would be that even women and men do not have the same uh, vulnerability to catching a cancer or a particular health status, as as we said. Another factor that contributes to our health status is what we call race or what we call ethnicity. And if you can see up on this subheading, I am calling them by social characters. Why do I call them by social? It's because these are characteristics that you cannot change. These are characteristics you are born with. You're either born to a specific race, you're either born to a specific sex, or you are born at a specific date of birth. And therefore, these are characteristics that do not change over time. Now, racial groups are defined based on one or more distinguishable physical attributes considered important in the particular society. For example, for us in Africa, we most times take our bisocial attributes as tribes. So, being that you are of this tribe, you are of this tribe, you're of the other tribe, another one is a Dinka, another one is a Nuel, the different tribes that we have in Africa or in our population are a key factor that we can actually relate and try to understand the health statuses. So in that case, you would be running analysis of a particular health problem to a particular ethnicity or tribe. So I will show you a downer example where you will see that the health problems are typically different. You would realize that there might be more cancer cases among people of this particular tribe, whereas among people of another tribe, there may be low cases. So this is what we want to understand, that these characteristics influence the health status of an individual. So while ethnic distinctions are not primarily biological or prolonged, it often leads to the development of distinctive physical characteristics. So, although this may not be linked to biological issues, but we can physically see that people of this tribe may be having higher chances or may be having more cancer or may be having a particular illness, so or may be seeking more health services of this type. We're using tribe or ethnicity to understand patterns of disease or patterns of health status in our population. Another characteristics is what we call the social-cultural characteristic. Social-cultural characteristics refer to those traits and the character individuals relate to their positions and statuses. So, an individual may have a social status. For example, you are married, that is a social status. You're not married, that is a social status. And this status, this social characteristic you're seeing here, also influences an individual's health status. While social traits are ascribed, while biosocial traits are ascribed, meaning that they are essentially at birth, the social cultural traits are typically acquired. You're not born with these cultural traits. These ones can be acquired through the actions of an individual. So social cultural traits are important not only because they indicate one's place in society, but also because there is a correlation with their health status. What is the first social cultural characteristics we're looking at? The first is the marital status. Early on in the study of the demographic in many of the studies for that correlate with health status, it was concluded that marital status was a predictor for both health status and health behavior, according to that study. Although the relationship is actually a highly complicated one, the categories of marital status for the discussion will be never married, married, divorced, and widowed. So we most times in research, in demographic research, we most times eliminate the word single, since it can be interpreted to mean never married, widowed, or divorced. So why we most times, of course, socially, many of us will always want to use the word I'm single, I'm what, but the word single is a general word to either mean that you have never married, or you are widowed, meaning your partner died, or you're divorced, or you separated. So instead of using the word single in most of our in most of our studies, it is only ideal that you use the term that you're never in union, or you're never married. So in this discussion of marital status, the most important four descriptions we shall be using is that either an individual is never married, is married, divorced, and widowed. These are the four characteristics we are going to use. And why it is very critical to use marital status in trying to understand health status is that, for example, most researchers by the mid 1980s counted couples living together as married, although there are those who could be cohabiting, what, but these are not official statements. These are social statements that people might be using. Separate individuals are not treated as consistent manner in the literature, but are most often listed under the official status. So you may be separated, or you may be divorced. So it is very clear that when you're developing your research tools, you do not intermix some of these words. If you said single, you may confuse your respondent. But if you say never married, or you're married, or you're widowed, or you are separated, then you would be able to get better or correct answers from your study. So, what is key to understanding your marital status relationship with health status is that you understand that the health status among singles is not the same as among among never marrieds is not the same as those among married people. If someone is never in union, the possibility that this one will get a sexually transmitted infection may not be the same as that those that are married, unless this one is practicing cohabiting, or is engaged in a sexual uh, intercourse, yet outside a relationship, or what people call unconsciously. However, there is a clear or thin line between some of the illnesses, the health status of an individual who is never married and one who is separated. But also, you would understand that the services these people of this category would want uh, to seek are different. So it affects both someone's health seeking behavior, but also the type of service that they would want to seek. So in that case, you would either find family planning more used among marrieds, because they are exposed to the chances of getting pregnant are higher, and therefore would want to avoid a pregnancy because they are in a marriage, than those that have never been in a in union. So these are all uh, issues that are health related, but they are being influenced by a demographic and social cultural factor called marital status. Another characteristics is income. Now, since income is the measure of socioeconomic status, uh, it is most frequently linked to health status. It's either directly or it's proxy for social class. It has been found that no matter what indicator is utilized, there is generally an inverse relationship between income and health status. This is true whether the indicators are outcome measures, disability measures, or utilization measures. There is a strong inverse relationship between income level and morbidity for both physical and mental disorders. As income increases, the prevalence of both acute and chronic conditions decreases. When symptom checklists are utilized, the lower the income, the larger the number of symptoms identified. Not surprisingly, members of lower income groups assess themselves as being in poorer health than do the more affluent ones. While 21.8% of those living at or below the poverty level considered themselves in poor or fair health, only 4.3 of those with household incomes 4 times the poverty level reported poor or fair health. So what happens is that income influences one, how or where an individual utilizes a particular health service, but it also helps in the measurement of an individual's risk into disability. It also measures an outcome of a particular morbidity level. So what happens is that you can realize in the trend that poorer individuals, their health seeking behavior might be lower than those that are fairer off or richer, in that a poor person may not seek health promptly. Why? Because it involves a cost. Before going to a particular health facility, maybe you'll be worried of your transport cost, you'll be worried of your upkeep cost, you'll be worried of the surcharge from the doctor. Whereas an individual with a fairly high income level will be very, very vigilant about their own health status, and therefore, if they detected any illness, they would apparently move in and get health care. However, accordingly to the risk, unlike in Africa, where you might be rich, but your chances of getting an accident are higher even when you're in a car due to road accidents. This may vary in developed countries, where it may be more riskier for an individual who is uh, on a pedestrian street to get an accident than that one who is in a car. In Africa, you may own a motorbike and you may easily succumb to a particular disability than an individual who is considered poorer and treks or walks. So these are just the teasing ways you could be able to understand uh, the trends of health status. So just as a take home, if you wanted to understand the trend, for example, in your health facility, I'm most times referring to health facility because if we're talking health related, it may be in the community, but you may not find data in the community. You may find data in your health facility. If you just went there randomly and chose a month and tried to understand, because if then the health facility was recording in their registers the occupation of their clients or their patients, you could just go and understand how many people from poor backgrounds or how many people whose occupation is farming fall sick of malaria vis-a-vis those whose occupation is different. You will be able to be asked to start thinking about solving particular challenges in your community. Another factor is education. The relationship between education level and health status presents the same pattern as income. Those at a higher education level are likely to rate themselves as being in a better health than those with less education. Typically, the education level, the lower the higher the education level, the lower the morbidity level. This is true also for both acute and chronic physical conditions. But this may not be what we call maybe an assertion that may not be disproved. Because one, if you look at our society today, those who are having high education levels, you stand to realize that they are even having more chronic illnesses. They may be more exposed to information that your feeding pattern may influence how you maintain your body. So if you grew fat, even if you're educated, you would still develop a chronic condition. And therefore, but if you see the trend, the majority who could develop acute or chronic conditions could be those who have low education level. But it is not the whole truth. It varies according to population. However, it is a very key indicator that you could just look at and could provide you with a good analysis of your society. So these relationships also hold for indicators of disability. For example, an analysis of data, which I will show you down here, found an inverse relationship between education levels and chronic conditions. So you see, what happens is that because an individual is having limited number of activities, yes, you are highly educated, but you do not have enough activity in terms of physical activities. When you leave office, you've eaten your junk, you've eaten your food, and you don't come and exercise. So what happens is that you get fat and you develop a chronic condition. Yet you are what? Yet you are educated. So this is what this study is trying to show you. Another characteristics here is what we call occupation, industry, and employment status. These ones affect how an individual as health status is. Occupation can be examined in terms of occupational status, blue collar, white collar, professional. In terms of specific occupation, in the first case, there is a direct and positive relationship between the status of occupation one holds and their health status. In general, the higher the occupational prestige, the better the health status. I am a CEO. We expect that because you're a CEO, you are vibrating around being at a better health status. However, those at a low occupational level tend to be characterized by a higher rate of morbidity and disability. Whereas the engineer or the chief engineer is there walking around for inspection, just inspecting what his shamba boys or these other how do they call them? These other boy fundis, these ones who are doing the actual work, as the engineer is walking around inspecting. For them, they are the ones holding bricks. They are the ones climbing up. So meaning that because their job or their occupation is at a lower level, the chances that a brick might fall, or the chances that they may fall from up there wherever they are down and get a disability or get sick because of the conditions they are being exposed to is higher. Another characteristics is religion. Perhaps the least well documented one. This is the one. The least documented relationship of demographic variable with health status, linking religion. to health status is one of the least documented relationships in demography. However, religion is relatively poorly studied in majority of our societies. So it is a little hard for you to link religion to a health status. However, some evidence you can see from Oman's statement. Oman was a Muslim. He suggests that religious involvement has beneficial effects on health status and mortality rates. And he realized that people's commitment or people's research has shown that people's commitment or association to religion helps them, especially in the mental health. So what happens is that because you may be having issues that are troubling you psychologically, religion might offer you some comfort and some mental counseling so that you could calm down. And studies have shown that such may help in reducing mortality, but also some health effects. So what would be very important is that when you're doing a study, would be that you would subject people who say they do not have any religion that they are believing in to those who say they have a religion, and you will try to weigh how many people without a religion have come to a particular health facility vis-a-vis those who have a religion. But also you'd want to know the number of days of illness an individual took to heal from a particular illness relative to their religion. So those are very key just characteristics you could look at. So studies have also associated higher frequency of church attendance with lower blood pressure, mortality from cardiovascular diseases, and physical disability. The lifestyles associated with strict religious groups, such as the Mormons and Seventh day Adventists, have been found to contribute to their higher health status. So, some religions have strict lifestyles. For example, there are religions that do not allow uh, taking of alcohol, and you would then find that in such religions, for individuals who could be following these religions religiously, you realize that there are chances of developing certain diseases that could be attributed to lifestyle are reduced. So, an example is also here that the Jewish population in the US is characterized by high levels of some conditions and lower levels of others. So it could be because of their practice. And just not to be biased, just to give you an example, you would sometimes realize that Catholic priests could be associated more with diseases, chronic diseases of cancer. If you to realize some of it, just if you did a random study in your area, especially in the Catholic community, of religious leaders, you would realize that possibly a majority of their death are as a result of chronic illnesses. Of course, you will need to do research whether it is associated to their religion, or it could be because maybe they are exposed to a certain level of vulnerability because of their practices. So those are issues that you need to look at. So just here, I've given you an example of what you could actually do in trying to understand the characteristics that I have been explaining. So you can see here in exhibit 10.6, you would see that it is called the age adjusted prevalence of selected health conditions for adults by selected characteristics. in the United States in 2010. So the characteristics here is age, sex, race, education, family income, and health insurance. So we are trying to understand how many children or how many people aged 18 to 44 years had diabetes, how many had kidney, how many had arthritis, how many had asthma, and how many had cancer. So if you were to look at age as a biocharacteristic, you would realize that people who were aged 65 to about 74 had cancer, more cancer compared to any age group. So then you can be able to relate that possibly the probability of an individual getting cancer when they clock that age in the US is higher. But also you would realize that kidney disease is also high as people age. So if you went to sex as another uh, demographic characteristic, you would be able to see that men, or I mean women, suffer more from arthritis than male, and more women have asthma than male. So these are just to show you what influences what. And if you came to race, you could also be able to identify. Then if you came to education, you see that the less than high education, uh, you would see they suffered more from diabetes. Possibly they don't have information on what they eat. So they could be eating food that is a factor, a risk factor for diabetes, and so forth and so on. You could analyze that as much as you want. So let us look at now that was how uh, demographic correlates with health status. But we want to also look at how demographic characteristics correlate with health behavior. And health behavior is both a preventive but also a therapeutic issue. Behavior meaning what type of lifestyle do you have uh, towards having a better health in terms of your preventive actions, but also in terms of uh, your therapeutic seeking or your health seeking behavior when an individual realizes a health problem. So this chapter is going to focus on the relationship between various demographic characteristics and the response of individuals and groups to health related conditions. That is their health behavior. So we intend to examine the so above we examine the how demographic correlates with health status, and now here we want to look at a natural extension of that discussion, that health behavior might be broadly defined to include formal health service utilization as well as the informal health behavior exhibited by the population. That's what I said. That how do you behave in order to have a health to maintain a healthy behavior, but also what is your health seeking or health utilization behavior. Some of these actions are taken by individuals who have been formally diagnosed as ill. However, however much health behavior is carried out by relatively healthy individuals who are attempting to maintain or enhance their existing health status or to prevent a decline in their health status. So now I have separated the indicators into there is what we call indicators of the formal health behavior in terms of uh, an individual who has been who is sick or who is ill, and we want to understand their formal behavior. One is their health services utilization. Okay, health professionals have developed a number of measures for determining the extent to which health services are utilized. Some of these indicators, for example, hospital admission or discharges, are generated through their routine record keeping. How many people have come to the health facility? How many have been discharged? Among others. So others include how many physician offices have been visited and how many drugs have been prescribed. All these are help to understand what the utilization of health service utilization, health services is like. Uh, some of the indicators represent standards for the industry for the formal health sector, while others are functional indicators that measure activity within healthcare. So we need to look at a formal indicator. We want to understand the behavior in which people utilize physicians. So this is one of the useful indicators to try and assess health service utilization. I hope you understand when I'm saying health service utilization. Do you understand that statement when I'm saying uh, health service utilization? Oh,
Yeah, yeah, you can understand.
we are proceeding well? Are we proceeding well?
Yes.
Okay, that is fine. So when I'm talking about health service utilization, we're trying to understand how many people actually seek healthcare services from the different healthcare providers. So one of the measures we want to use to understand their behavior is what we call the physician utilization as an indicator. It is one of the most powerful indicators to use. The physician is the pivotal practitioner in the healthcare system. Okay, some people call them clinicians. Some in some health care they call them physicians, and they are placed at the outpatient department, which is the triad, or which is the first entry point for any client. For any client, the WHO requires that the individual goes through OPD, is seen by what other people call clinician, is seen by what they call a physician, and then they can go ahead to utilize other services. So that is why this utilization of the physician is a key measure. So this is a more direct measure of utilization levels than hospital admissions, in that virtually everyone uses a physician's service at some time. So we can use how many individuals in a population have seen a physician to understand what a population's health behavior is like. In some cases, however, the level of physician contact might be calculated with the inclusion of the telephone contact and physician visits of the hospitalized patients. Physician utilization might be calculated in terms of annual visits per thousand population. For example, if a community of 10,000, if there is a community of 10,000, we would expect to generate 30,000 physician visits per year, meaning that an individual must or could visit a physician thrice a year, 3 times a year. So if there was a population of 10,000 people, we expect that there are 3,000, there are 30,000 visits. If you went to a health facility in the outpatient register, you would be able to see OPD attendance or outpatient utilization, and there is always reattendance and attendance and new attendances. So you would be able to virtually understand how many times, if you subjected the OPD attendances to the population, you would be able to understand how many times an individual visited a health facility, and you'll be able to understand their health seeking behavior. Physician utilization varies by specialty, so in many cases, rates for physician visits are figured separately for the various specialties. Another indicator is utilization of other healthcare personnel. So there are other types of personnel for whom utilization rates might be calculated. Most of these, like physicians, are independent practitioners who practice without supervision of other medical personnel. Examples of these are dentists, optometrists, podiatrists. We're looking at chiropractors, nurse practitioners, and physician assistants. You can also include mental health counseling. So apart from physicians, we also want to know how many of these people utilize other services as a way of trying to understand their health seeking behavior. Another indicator of measurement of formal healthcare utilization or healthcare behavior is what we call treatments administered. Some of the most direct indicators of health service utilization are those calculated for various diagnostic tests and therapeutic procedures. So what happens is that when an individual is admitted and visits a physician, uh, it gives us the behavior that an individual is having a health behavior of visiting healthcare. However, we want to understand the issue of treatment or a therapeutic, meaning that an individual has been diagnosed and has been treated. So if an individual is put on a treatment, then we can be able to know how many of these have successfully sought healthcare treatment. So diagnostic procedures include the various clinical tests. So a large proportion of them, in fact, are performed on a well individual who are simply obtaining routine preventive examination. So what happens is that in therapeutic procedures, we are giving treatment to individuals who are having a particular health problem. But if it is a diagnostic test, we want to look at an individual who has just come to try and do a routine checkup and see, do I have any problem or I don't have any problem. So the more diagnostic tests individuals come for, you will understand that their health seeking behavior is good because they are coming to check how many or what their health status is. However, also for individuals who are coming for therapeutic cure, you would be able to understand that there are more individuals who are coming to seek treatment rather than those that do not come. Then you can be able to judge their health seeking behaviors. Hospital admission is another. You understand that most frequently people do not virtually want to go to health facilities because they say it is long queue, because they say the health workers are harsh on them, because of a variety of reasons. But we want to use how many people in a year or per thousand population were admitted in a health facility, so that we can be able to understand how many people are seeking health care or what we call specialized health care. Although the numbers are generally comparable, a noteworthy exception is found with regard to maternity cases. one person or a pregnant woman is admitted to the hospital, but two persons, the mother and the newborn, are discharged. So, given the fact that the childbirth is a leading reason for hospitalization in many of our areas, this distinction becomes important in tracking of hospital utilization. So, other factors that may sometimes result in discrepancies between the numbers of admission and discharges for a particular institution are the differential defining of expired patients or internal transfers as discharges. So you if this is what we call the inpatient patient data. So what happens is that when someone is hospitalized, you're able to understand conditions under which an individual is hospitalized. Then it can draw an individual or a researchers or the hospital biostatistician to understand what is the rate or what is the major disease that is leading to uh, hospitalization of individuals or the leading rate for hospital admissions. So, if, for example, in this discussion here, they are telling you that some admissions or discharges may increase. Discharges may be higher than admission, and then you start to question. But this may arise as a result of hospital admissions in maternity. So you may have hospital admissions in maternity because of pregnancy, and these women will give birth. And when you're discharging them, you will discharge both the mother and the baby. So this may lead to rises, but the fact that it gives you an eye into trying to understand what is the most reason for hospital admissions helps you understand how this is critical in trying to plan. So another indicator formally that we want to use to understand population health behavior is what we call patient days, an indicator related to hospital admissions, of course. This indicator is calculated like hospital admission rates with respect to the number of patient days generated per thousand population. So you would be able to understand how many days your patients spend in a particular a month or period in the hospital. In some ways, this indicator is a better reflection of utilization of resources than hospital admissions. So measuring patients' days serves to adjust for variations in the length of stay for various conditions. Two hospitals with comparable admission levels may generate quite different numbers of patient days because of differences in their patient mix. For example, Hospital X and Hospital Y may both report 5,000 annual hospital admissions, but they may record patient days totals of Hospital X may say their 5,000 patients spent 15,000 days, and Hospital Y would say that their 5,000 uh, clients uh, spent 30,000 admissions. This could happen, for example, if the former were a woman's hospital. So if the hospital X was a woman's hospital that is specializing in obstetrical care, and the later were a general hospital with a more typical patient mix, it would mean that like admission rates, patients' days may be calculated in terms of diagnosis. So we would expect that mothers for hospital X, that is an obstetric hospital, they admitted mothers for deliveries. And then between in 15,000 days, these 5,000 mothers were able to deliver. However, Hospital Y, even if they admitted the same number of patients, or they had the same number of hospital admissions, their patients spent more time, possibly because they have a patient mix. This hospital is getting both pregnant mothers, but it is also having cancer cases, but it is also having respiratory cases, it is having all other issues, maybe orthopedic cases. That is what we're trying to explain in that statement. Another indicator that I would want to look at is the length of stay. One other indicator related to hospitalization. Remember, these two, the days spent and the length of stay, are both indicators that are drawn towards hospitalization. This is typically reported in terms of average number of days a patient remains in a facility. So there we are looking at the total number of days people may be spending. We are trying when we're looking at the number of days here, when we're looking at patient days, we are looking at this patient spent 8 days plus the other patient spent 20 plus the other patient spent 30. That is what we're talking in patient days. But when we want to look at the length of stay, we're trying to look at the average number of days a patient spends. So from the 1,000, if if this was let me just use this example that we had here, this one. So for hospital X, we're saying that for hospital X, we're saying that they had 5,000 uh, admissions, or people who were admitted in the hospital, vis-a-vis the 15,000 days they spent. So if you wanted to get the length of days for hospital X, you would have 15,000, which are the days, divided by 5,000, which is the patients. So it would mean that the length of days a patient spent in hospital X was 3 days. That is what we are explaining here in the length of stay. The average number of days a patient remains in the health facility. So that is the that is what that thing. So we want to look at other indicators that are facility based. There are several other facility indicators that may also be mentioned, which are, while not all of them are significant, each is important in their own way. All, in fact, have a particular linkage with some aspect of demographic composition. So these additional facilities for which utilization rates may be calculated include hospital emergency rooms, hospital outpatient departments, freestanding emergency. So we may not understand that these hospital indicators are very necessary, but what we are very sure, or what we can understand here, is that they have a linkage to demographic factors. For example, hospital emergency rooms can be linked to income levels of an individual. That an individual who might be owning a bike might be having a higher chance of going to an emergency room. This is what that interpretation is having. Uh, that also a married couple could be could be frequenting, or could be having a linkage to having a freestanding minor medical center. In case of any complication of pregnancy, they could visit these facilities. Some of these facilities have come to compete with traditional sources of care, especially hospitals. As the emphasis has shifted towards more outpatient care, these indicators have become increasingly important. So most times, most services are being offered at outpatient level. So it is key that you try to analyze the characteristics of patients that are coming to seek this care. Okay, so that slide is roughly telling you what we've been discussing, that utilization rates for these facilities may be calculated in the same manner as the hospital admission rates. Another indicator that we don't pay attention to, but is very key in trying to understand service utilization, is an indirect indicator of the level of health services utilization. This is the type and the extent of health insurance coverage for individuals and families. Historically, this would have simply involved the calculation of the proportion of population covered. However, witnessed a proliferation in the variety of financial arrangements available for reimbursement of health services. So, we would want to understand in trying to, if we wanted to understand what our population's health behavior is, we would want to know how many people have insurance coverage, so that you would know, these people are having better health seeking behavior because they already understand that they are at risk. And therefore, because they are at risk, they will be able to, they have already planned because they have covered themselves. In case of any illness, they will go and seek a health care. So we would be able to understand that this population that has insurance has good health seeking behavior. Most times, in this indicator, we could just get the number of people who are covered vis-a-vis the population, and we would be able to get our health-seeking behavior. However, of late, there are different financial arrangements. Instead of people seeking healthcare directly, they go and make agreements with the health facility, but there's also out of pocket, but there's also there are also people who make agreement with financial institutions. So insurance coverage may not be the only method or arrangement that is helping people seek health services. However, it is important that you try to understand how many people have coverage on accessing healthcare, so that you'll be able to understand their health seeking behavior. Another issue is drug utilization. Drug utilization is another indicator of the use of health services that is sometimes used. This typically focuses on the consumption of prescription drugs, since these, rather than over-the-counter medicines, are thought to be more closely reflect actual utilization of formal healthcare system. So while the level of drug prescription can be determined by the physician and pharmacist, rates of consumption of non-prescription drugs must be determined more indirectly. What is a constraint in trying to understand drug utilization is that people are doing self-medication. However, if people were seeking healthcare from uh, designated health facilities, you would be able to compare the rate of prescription and then the rate of utilization of drugs in this health facility, and you will be able to understand how this plays into uh, what we call health behavior of the individuals. In any case, these are important demographic differences in the level and types of drugs prescribed and non-prescription drugs that are purchased. So part of these differences can be attributed to variations in lifestyle characterizing different groups in society. So some individuals would feel they cannot go to the health facility because their income is low, and therefore they go for self treatment. Just go and buy over the counter and get treated. Some people would want to go and say, do you have a medicine? Do you have some medicine? Because they are not learned, and they pick from their neighbor and take. So this is what the interplay that we are talking about. Okay. Are we still continuing any? Because the next slide is on demographic correlates, how demographics correlates with health behavior. No, I think we covered that. We covered that, right? My slide has skipped a little, but let me just show you how far we have reached. Okay, I think we're here. So, colleagues, I'm seeing that our time has gone a little down. Are we still able to continue?
Can you continue rolling up because it seems like some other thing we have covered them in the middle slide.
Yes, that is what I'm also seeing. Yes, this is virtually what we have covered, and but it is just giving you more explanation over how these would affect uh, how demographic factors would affect our health behavior. So let me just, as I conclude, because we're also time up, as I conclude here, I just want you to look at this particular thing. Are you able to look at this figure in here? The figures that this photo that I have shown you, is it clear?
Yes.
Let me zoom it a little bit there. So if you can read up there, it is telling you that the length of time since the last physician visit for those 18 years and older by selected demographic attributes. All these attributes that I have been discussing are actually here, but we are trying to ask ourselves how many people of this age people of this age, when did they last see a physician? So that we are able to know what is these people's health seeking behavior. So if you looked at age, you would see that it is rather older people. If we were to see 6 months or less to 1 year, so in the last 6 months or less than 1 year, meaning about 7 to 12 months there, we see that it is actually elderly people who are 70 and 75 and above who are seeking health care. But if you see 6 months, people who are frequently seeing the doctor are people who are 18 to 44. Looking at males, you realize that there are more female who seek who sought health care in 6 months or less to 1 year. You see that it is trying to show you that the health seeking behavior of female is more than those of men. Possibly, you could attribute this to our social structure that men are born to be strong people and therefore they do not just seek health care. You only seek health care when you are the so-called badly off. So that is what it is trying to show you. But also it is trying to show you here that in terms of income level, that people who had $100 and $100,000 and above were the ones who sought healthcare most in the last few months. Likewise, the trend continues for those who are highly educated. You see, those who have bachelor's degree are at 72, and therefore they have sought healthcare. Their seeking behavior is better off than those who are less than high school. If you also look at marital status, those who are never married, I mean, those who are married, you see, those who are married have more touch with healthcare than those who are not married. And you could give numerous reasons. Possibly they are going to healthcare because they want to seek maternal services, they want to seek family planning services, but also because maybe they want to take their children to seek healthcare. So there are various reasons as to why it is very critical for you to relate demography or demographic characteristics with your health status, but also with your health behavior. So finally, we want to look at the policy implications. Worth noting is that the correlation between demographic characteristics and health behavior, particularly on the use of formal health services, has major implications for health policy. Further, the fact that the disparities that exist in the use of health services and in the manner in which services are delivered to various segments of the population further emphasizes the importance of demographic information for policy setting. So, because of the different implications that you have seen, how demographic characteristics influence health behavior and how they influence health service, it is very important that policymakers look at how to tackle these issues. That is what the policy implication means. Virtually every other health policy issued being discussed today reflects the contribution that demographic factors is making to changing health statuses and changing patterns of service utilization. So, in conclusion, the patterns of health services, both in utilization, in status, but also in behavior, are virtually influenced by demographic factors, which we have discussed herein above. Unless we have any questions, I would want to conclude there. Any question? If not, I hand back to Ivan.
So for me, I think it is very clear.
Okay, that is okay. Ivan,
Yeah.
I think I've concluded.
Okay.
Since there are no questions,
Thank you
yes.
very much, Mr. Aloysius Sabit.
Yes. So we needed to finalize the module. There are just a few slides that we could handle on Monday. I know that the director had asked that we finish in a week, but I'm thinking we could introduce and summarize on Monday. I don't know how possible that can be.
It's okay.
All right.
Yeah, so it's not a question, just like asking,
Mm.
are you doing a recording at the moment?